when we last spoke, you said something that struck a chord that we've lost the core mission of medicine because we've become embroiled in the systems of healthcare. So I just wanted to unpack that a little bit. What is the core mission of medicine and how have we gotten away from it?
So again, medicine is a science and an art to make you better, but it is also to deal with disease. You come to us with a problem, we solve that problem. We don't eradicate disease. We don't remove it. We just help make sure that it doesn't harm you or kill you. Right? We manage it. Cancer we don't cure. We just keep it in remission. We don't take away high blood pressure. We give you a medication to manage your high blood pressure. So I think that there is sort of this tendency to think that that medicine is sort of like, if you do it all correctly, you will eliminate disease. And I think, again, that gets back to the public health world. A lot of these MD, MPH people that are like policy leaders that sort of blur those lines between medicine and public health, because public health is all predicated on, yes, we're going to eliminate this and eliminate that and eliminate this through initiatives. So I think that, I like to think of healthcare and medicine as somewhat separate, and that as we move forward, our technologies, again, the doctors should be in control of the medical part of that equation.
Right.
And this is where we've lost control of that.
Yes. And I want to circle back to those physicians being in control of that in just a second. But we've talked a lot about the patient-centric view, but not as much about the physician and nurse side of the equation and how the systems of healthcare, the business models of healthcare are impacting people like your livelihoods and quality and missions. What is like the boots on the ground physician or nurses, staff's perspective on how you're being constrained or what your life is like?
So medicine is driven by data, right? We take vital signs, we take information, we take your blood tests, we take your physical exam. We look and we obtain data. In the last 15 plus years, the data acquisition has gone beyond the needs to make a medical decision. It has included taking all sorts of information about you, your financial data, your social security, your credit score, all those other things, right? The insurance, and then put on top of that, people are trying to acquire more information. They want to know they want us to be data gatherers. So the electronic records have been really. When they were introduced, at first they were a wonderful repository of important information. You could get your x-ray information, you get your blood test. And again, even when I was a resident, we had electronic records. And it was wonderful because you didn't have to go down to the medical records department and pull a chart out. You could sit in the ICU and suddenly pull up that person's op note from the last time they were there and know exactly what was wrong with them. So there was a tremendous efficiency in that. And that's important data that we use to make medical decisions. Over the course of the last decade or so, it's evolved into an invoice. It has become a billing interface. And we continually add more and more information that's no longer relevant to the patient outcome, but instead to some other reason, other purpose. That other purpose it's related to another purpose, and the other purpose has to do with whether it's gathering it to set actuarial tables for an insurance company, whether it's to set a premium, whether it's to unfortunately market your ICD-10, market your diagnosis to know look, there's a population that is has this type of or highly obesity population. They're going to need a lot of diabetic medications for this zip code or something, right? There's all sorts of things that data now is leading to in the world of marketing and business. And so when a nurse, my nurse in my office, who's a brilliant nurse, she's like the greatest nurse ever, and she's an ICU nurse for 50 years, she talks about the 75-minute hour. Okay, so when a nurse in the ICU is trying to take care of you, you're critically ill, they're hanging medications, they're talking to consultants, they're, turning the patient, they're, recording vitals. The way the whole system is structured, there's so much data that has to be entered into the electronic record in particular ways. It's impossible to do all of that and take care of the patient in 60 minutes per hour. So the tasks go beyond that. And I was talking to an informatic person yesterday who put in another workflow in our pre-op hold area that would require the doctors to electronically enter all of their pre-op antibiotics because they thought that was a safety issue. And I said, well, we have a conversation at the bedside with the doctor, the surgeon, the anesthesiologist, the nurse, the patient about that antibiotic, right? Now you're going to get somebody who's remote, who's running late, who's just going to go on the computer for their 10 cases a day and pop in the same antibiotic just to make it more efficient. And it's like, you can't tell me that that's not going to lead to problems. Maybe somebody has a new allergy or it just didn't get recorded. Many times patients tell us, oh, I'm not allergic to anything, and they tell the nurse something differently. So the nurses and doctors are very, very frustrated over the amount of data that we have to acquire, the amount of time we spend away from the patient, and we have very little recourse. When we complain, they tell us we're not technologically savvy. You tell a surgeon who uses new technology every day, well, you guys aren't tech savvy. So now when they tell me that yesterday, Dr. Muto, you're not tech savvy, I raised my hand, I said, I actually created a tech platform. So you can't say that to me anymore. But this is the problem. So doctors and nurses are very, very frustrated, and it has to do with data, all of the data acquisition and the time spent away from patient care.
Got it. And is it at that breaking point? Because I've seen so many different stories, in particular through the pandemic, of physician burnout, of nurse burnout, of people feeling overworked and underappreciated. Where are we at today?
Oh, huge. Well, the pandemic just kind of unveiled a lot of weaknesses in our system to begin with. The nurses were asked to work these crazy shifts, and then oftentimes they were replaced or substituted by traveling nurses that came and made more money than they made. So nurses actually quit and started to travel and have their own hospitals. And so you had tremendous hours that were expected. It was a really, pandemic emotionally was difficult because so many patients were isolated from their families. The nurses at the bedside became their family. So there's a huge emotional toll. I would say PTSD for sure for people that were in those ICUs at the height of the pandemic. It was, I think coming out of all of that, you saw big retirements. You saw lots of people who said, hey, I'm done with medicine. A lot of physician colleagues of mine have decided that's it. The pandemic was kind of a press and pause for most doctors, where you didn't have control of what was happening. You obviously didn't see as many patients as you used to see because everything kind of stopped. And when you came out of that, many doctors said, hey, I was only working 3 days a week during the pandemic. I think I'm going to continue to work 3 days a week. So a lot of doctors came back kind of half time, and other doctors who said, I'm probably going to retire because they saw it differently. And so we have a huge exodus in medicine on both the nursing and doctoring and staff, medical assistants, front ends, receptionists. There's a huge exodus from healthcare right now.